How's it going, guys? We have a past level question for Endocrine. 42-year-old dude undergoes a total thyroidectomy for medullary thyroid cancer, often associated with the RET proto-oncogene. It need not be full-blown MEN2A, MEN2B. Of course, both MEN2s, you're going to have medullary thyroid cancer, pheochromocytoma. MEN2A, you add parathyroid adenoma or diffuse foral gland hyperplasia. MEN2B, you add marfanoid body habitus, mucosal neuromas. They can just straight up tell you, dude has medullary thyroid cancer, no other findings, and the answer is still just RET. You do not have to have all findings in a MEN constellation. Now, this dude had a thyroidectomy with subsequent hypoparathyroidism because we remove the parathyroid glands when we do a thyroidectomy. Calcium's low at 8.2, should be 8.4 to 10.2. Phosphate's high at 4.7, should be 3 to 4.5. And then we're just asking which of the following is a normal physiologic function of PTH. Choice A, decreases late DCT. Calcium channel insertion is wrong. It's the opposite. So PTH normally upregulates a calcium channel in the apical membrane of the late DCT. It does three things in the kidney. Number one, as I just said, it's going to upregulate an apical, which means on the side of the urine. Basolateral means side of the blood. So upregulates an apical calcium channel in the late DCT, allows for calcium to move out of the lumen into the cell. Second thing it does, decreases phosphate reabsorption in the PCT. So PTH downregulates three different types of phosphate symporters in the PCT. So if PTH is low, we have too much symport activity, too much phosphate reabsorption in the PCT. The third thing PTH does to the kidney is it upregulates 1-alpha hydroxylase, which converts inactive 25D3 into active 125D3. Latter goes to the small bowel, increases calcium and phosphate absorption. Wrong fucking answer. Choice B, decreases phosphate absorption in the DCT. Wrong fucking answer. So as I just mentioned, PTH is going to decrease phosphate reabsorption in the PCT, not the DCT. It matters. USMLE cares. We're talking basic physio here, first year med student stuff. Wrong fucking answer. Choice C, directly stimulates osteoclast and induce bone resorption is wrong. So the whole elaborate fancy mechanism of how PTH it's going to bind to its receptor on osteoblasts, not class. And although osteoblasts build bones, so it seems paradoxical, when PTH binds, the osteoblast is going to express rank L, binds to rank receptor on osteoclast, and in turn, the osteoclasts induce bone resorption, so it's an indirect mechanism there. You just have to be mindful of the whole pathway, because USMLE can ask you any number of permutations. They can give you a PTH question where the answer is increased osteoclast activity. Yeah, osteoclast activity is increased. It's indirect, but it's increased. But you need to know it directly binds to osteoblast, PTH, okay? And then it indirectly activates osteoclast. Wrong fucking answer. Choice D, increases 25-hydroxylase activity in the PCT. Wrong fucking answer. So being a little bit slick here if you don't know your physio. As I mentioned before, upregulates 1-alpha hydroxylase, not 25-hydroxylase. Wrong fucking answer. Choice C, increases intraosseous paracrine signaling. Correct answer. Paracrine just means hormonal signaling in the local vicinity. Okay, so when we talk about rank L, rank interactions, that's paracrine. The same way, for instance, tangentially, in the thick ascending limb of the loop of Henle, you have paracellular calcium and magnesium absorption. So that prefix para is around or next to. So you have rank L, rank interaction from the osteoblast to osteoclast. It's how PTH functions. And it's an easy answer. Some of you knew it right away, but then you had to just quickly go through A through D and eliminate to get there. Choice E, correct answer.